Good morning, everyone. So I'll I'll be start I'll be it, I'll be starting with evaluation of meibomian glands structural and functional changes in the patients of vernal keratoconjunctivitis using a non-contact meibography. So a little bit of background and association between the severe ocular allergies like vernal keratoconjunctivitis and atopic keratoconjunctivitis and dry eyes is known. And the proposed pathophysiology is that there is conjunctival inflammation, there is post-inflammatory surrounding tissue remodeling, and the adjacent structures like the meibomian glands are affected, and there is anatomical, structural, and functional alterations. So this is known. But the literature regarding the effects in VKC patients is very scant. The literature is very scant, and the imaging modality that has been used is confocal, which has its own limitations. Like it do not comment on the functional aspect, and the area that it covers is very less. So the aims and objective of our study was to assess the structural and functional changes in the meibomian glands in the patients of VKC as compared to the normal age-matched controls using the LipiView 2. So the various parameters that were assessed under the functional category were the lipid layer thickness, meibomian gland patency, and the quality. The structural aspects that were covered were the MG dropouts and morphological alterations. And blink rate was also assessed in this. Materials and methods, it was a prospective, observational, and a comparative study with 50 patients of VKC that were compared with 50 patients of age-matched controls. The inclusion criteria in this, we have included moderate, persistent, and severe grades of VKC using the Bonini's grade of classification between the age group of 8 to 20 years, and all the children with any active conjunctivitis, use of any medications known to affect the meibomian glands, or use of any immunomodulators, they were excluded. I want to highlight the fact that grade 4 and 5 Bonini classification were excluded because they had a giant papillae and they obscured the meibomian glands, and the children were usually so symptomatic that they will not be able to complete the examination part. So our testing strategy was slit lamp examination followed by dry eye evaluation followed by meibography. So under dry eye evaluation, the battery of tests were done like T-BUT, Oxford grading, Shermer's 1, and Meibo scoring, in which the expressibility and the quality of the meibum that was secreted was assessed. So we used this Korb Meibo gland evaluator that gives us the specific pressure for the evaluation, and the Meibo scoring was done. And under meibography, the gland imaging was done, lipid layer thickness and partial blink rates were assessed, all using a single machine, that is LipiView 2. And then the images were retrieved, and manually using the ImageJ software, the dropout area was calculated. So the MG dropout percentage was calculated using the dropout area divided by the total lid area, and it was then categorized using dropout, this Meibo gland dropout. So our results were the age of the cases and control was comparable, the sex predilection was comparable, and laterality was comparable. We had 38 patients in the moderate persistent grade and 12 eyes in the severe grade. And we had all the three varieties of the VKC, that is palpebral, limbal, and mixed. So these were our results. I'll try to summarize all this, the significant values. So to summarize, the tear film breakup time, it was less in cases than in controls, but the Shermer's was normal. That means it was an evaporative type of dry eye. The Oxford grading was more in cases, suggesting that there was ocular surface damage in cases. The Meibo scoring was more in cases that there was poor quality meibum that was secreted associated with increased plugging, and there was upper lid dropout, lower lid dropout. That was Meibo grade was more in cases than in controls. So hence suggestive that there is a structural damage seen in VKC patients. And lastly, the lipid layer thickness was less in cases than in controls, suggesting a functional damage. On top of that, we made some correlations between there was a fairly positive correlation between the meibomian gland dropout and Meibo scoring. This suggested that the more the dropout, the poorer the quality and the quantity of the meibum that was secreted was there. And there was a moderate negative correlation between the tear film breakup time and MG dropout. That was suggestive that more was the dropout, less stable was the tear film. And there was, we found that there was no correlation between the lipid layer thickness and the MG dropout. So we concluded that there was a functional reserve that might be present in the meibomian gland that was compensating for the lipid layer thickness. So to conclude, The children with the allergic dry eyes have primarily evaporative in nature, associated with thinner LLT and manifest as ocular surface damage. So there is a vicious cycle of inflammation both due to the ocular allergy and due to the dry eye. So dry eye need to be co-managed in the patients of VKC. Thank you.